फुल स्क्रीन कर दीजिए, पावर पॉइंट पे लगा दीजिए. For sarcopenia cutoff point, as you all know. So coming to the SWAN study, what today I am going to speak on muscle loss versus fat gain. And I am really thankful to the organizing committee to giving me the chance to speak on this topic in this prestigious national conference. And just coming to the topic, I hope I'll finish on time. So muscle loss versus fat gain, as you know, that midlife body composition changes. They can be silent, but they are clinically loud. Visceral fat gain increases cardiometabolic risk even when the body weight changes modestly. So loss of muscle mass and quality reduces the strength and mobility of the women in premenopausal and menopausal phase because of the reduced resting energy expenditure via their reduced muscle mass. The combination sarcopenic obesity is more linked to higher risk of diabetes, cardiovascular and disability, and early detection is needed. So I think after this session you'll be understand the what is fat mass. Fat mass is total amount of fat in the body encompassing of adipose tissue under the skin around organ, that is visceral fat, and within the tissues. While lean mass is total weight of the body minus all fat mass, that is muscle, bone, organ, connective tissue and connective tissue weight. And how this changes, fat mass and lean mass changes across the final menstrual period, we will know after this deliberation. So fat mass, as you all know, is subcutaneous, visceral and ectopic, and lean mass is skeletal, organ and water connective tissue. So how we can measure these things? So DEXA is the gold standard for measuring total and regional fat, lean mass and bone mineral content. The next is bioelectrical impedance analysis. It estimates fat and lean mass and visceral fat area. Other measures are anthropometry, as you all know, waist circumference, waist hip ratio, BMI, mid-arm circumference, skin fold thickness, and functional are grip strength. So which is better and which we can do and which we should do. So these are all common methods of body composition, and hydrostatic weighting and air displacement plethysmography, these are the old methods. Now, the muscle mass measurement primary methods include DEXA, that is dual energy X-ray absorptiometry, and BIA is bioelectrical impedance analysis along with CT MRI. This is being used for only advanced assessment. So gold standard for body composition analysis is appendicular skeletal muscle mass, which is expressed as ASM upon height square, and it represents skeletal muscle corrected for the height. And the cutoff value for men is less than 7 kilogram per meter square and women less than 5.5 kilogram per meter square, and it is highly precise method. Bioelectrical impedance analysis, this will estimate body composition including body fat, lean muscle mass and total body water. And it works by sending low electrical current through the body, and this current will measure the resistance which will be provided to the current, and different tissues create different resistance to that particular electric current, by which we knew what is the percentage of body fat and what is lean muscle mass. So how we interpret the result? In fact, we will come to know about what is the percentage of body fat, regional body fat, whether it is subcutaneous or whether it's visceral, whole body of segmental fat distribution. In muscle, we'll know about muscle water organ, etc. And bone, as you all know, bone mineral density, bone mineral content, and DEXA is the gold standard for BMD and bone mineral content. While for muscle, BIA is the better method. So as you all know, EWG SOP guidelines says that muscle strength is the most important factor in sarcopenia diagnosis, and along with muscle mass, it will confirm the diagnosis. And physical performance, it will use to determine the severity. So these guidelines cutoff points nutrition occur, especially in urban families. High central adiposity and metabolic risk can occur at lower BMI. Therefore, measuring waist upon waist hip ratio and preserving muscle are central to prevent various strategies. Diet, as you all know, so, vitamin D deficiency is widely reported. Deficiency can worsen bone and muscle outcome. So, in my last slide, I have 5 points to remember. Menopause shift composition, fat gain accelerates around final menstrual period, lean mass drifts down and then stabilizes. Central visceral fat is the main risk factor. So waist and waist hip ratio matter and more than a uh, simple weighing scale or BMI. Normal BMI does not rule out high visceral fat risk, especially in the South Asians. And best intervention is resistant training 2 to 3 times per week, adequate protein intake, supported by aerobic exercises. In India, early menopause, high central adiposity burdens, so start preventing in early to mid 40s. Thank you all. Protein quantity to 2.4 gram per kilogram per day and reduce 40% of calorie deficit. If your general body condition is okay and your renal kidney tests are okay. Exercise 6 days a week, resistant plyometric training should be done and cycling should be done. Plyometric training versus high intensity internal training, both of them should be done. Plyometric is jump based movement and HIIT is cardiovascular training. So resistance training, as you all know, are the various weightlifting exercises which increase the number and size of the fast twitch muscle fibers. And they should be progressive resistance training 2 to 3 times per week, improve physical function, gait speed, timed get up and go, balancing, and reduce the rate of declining of muscle mass and strength. Then accelerate during the transition and then plateau post menopause. While the lean mass changes are smaller, slight rise in the lean mass in premenopausal phase, followed by decline, and then it remain stabilize. But if you don't even exercise, then this goes on down uh, over the period of time. So BIA study was done. It adds something special other than a SWAN study. It assess the visceral fat area and multiple lean compartments. That is lean body mass, skeletal muscle mass, water, protein, mineral estimate, which is a further better thing. Find higher waist hip ratio and visceral fat area in post menopause. So BIA study is a better study than SWAN study. And as you all know, there are some myths about same weight, different body. Everybody goes after reducing weight. But over the period of time, small losses of lean tissue can be masked by fat gain. So net weight change will be zero. But central fat gain raises and risk even without any major changes in BMI occur more. So tracking of waist circumference, waist to hip ratio should be done in spite of doing BMI. So there are three interactive drivers, which these mechanisms which tells us why fat rises and muscles are hard to keep at the age of perimenopause and menopause. First is hormonal, that is estradiol falls and FSH rises around FMP, and second is metabolic, that is resting energy expenditure and spontaneous activity decrease due to sarcopenia and anabolic resistance increases. And third is inflammatory. Visceral fat is a metabolic active and it increases cytokinin that will promote insulin resistance and muscle catabolism. So common menopause adjacent muscle changes, I have already told you. Small decline in lean muscle can coexist with large decline in strength. Muscle quality fall, anabolic resistance agar, and lower muscle mass reduces glucose disposal capacity and resting energy expenditure. So screening idea is to treat declining strength as an early warning sign, even if your body weight is stable. So central adiposity is the key shift. Visceral fat behaves like an endocrine organ, higher inflammatory signaling and metabolic risk. So as I have already told you, women with normal BMI can still have a visceral fat. They are thin outside and fat inside. So in this chart, the sarcopenic obesity is the highest risk combo in which there is low lean mass and higher fat. Menopause can shift composition diagonally. It will increase fat and decrease the muscle quality. And this we can counteract with resistance training exercises. So various health consequences can be metabolic, can be cardiovascular, functional, frailty, fall, slower gait speed, reduced impedance, reduced independency, and bone muscle fat crosstalk, which changes cluster together in the midlife. So there are certain assessment tools. Minimal are waist circumference, waist hip ratio, body weight, BMI, grip strength, and basic lab tests like glucose, HbA1c, lipid. And there are certain enhanced tests that are DEXA, BIA, functional testing, gait speed balance, and diet and activity screening. That should be also done. So prioritization, what changes composition? So resistant training, aerobic activity, protein adequacy distribution, and sleep and stress. This also influence appetite, activity, and metabolic regulation. If time is limited, then 2 to 3 days per week of resistant exercise should be done along with daily walking as a high ROI starting point. So this I have already discussed. Exercise, squat, hinge, pull, push, carry, core. This should be started and progression should be done. This is regarding nutrition, how to